Mm. Okay, we are live, ma'am.
Yeah, good evening, everyone. So I welcome all of you to this third masterclass on laparoscopy. This is a very important topic, and after a couple of discussions, we thought that anatomy of uterine artery, though it looks very simple, there are certain things which need to be discussed practically so that we are all aware as to what challenges we can face when we are actually doing hysterectomy, either when we are coagulating uterine artery at the origin or when it enters the uterus close to the uterus. So we are going to talk about the anatomy, and this session will include the embryology of the uterine artery, which may be relevant for all of us in our both like obstetric practice and also in our gynae practice. So let's hear from Dr. J as to what he has got to say about this.
So, hi everyone, and I'll be starting with the screen sharing because it's good to draw and explain this topic. So, the screen is visible, right, ma'am?
Yeah.
Okay. So, whenever we are talking about anatomy of the uterine artery, two or three very important things which probably we all need to understand as far as understanding some aspects of embryology of the uterine artery is concerned. Okay. So, if I just draw a fetus to start off with, so if I just draw the abdomen of the baby, something like this. Okay, this is where the umbilicus is, correct? And in the umbilicus comes the umbilical cord. So umbilical cord is obviously attached somewhere in the placenta, and then it comes to the baby. And then when it is in the baby, it actually divides into two branches, correct? No, this is what we call as the umbilical arteries, correct? Which is dividing inside. Now this in between this is actually the bladder, correct? Remember one thing, very interesting thing about uterine artery. I'm sure we have studied it, and I'm sure probably we have forgotten it. You know, uterine artery embryologically origins from the Mullerian region. But you must understand this very important thing. After the child is born, this guy, okay, this umbilical artery actually atrophies. And once it atrophies, it forms something called as, I'll just write it down, the anterior ligament, okay, or the lateral ligament. I'm unable to write it actually. Why? That is because, you know, this uterine artery, which is going to be formed from the mesonephric duct here, okay, both these people are going to join inside, and at that juncture, you will have the formation of the uterine artery. Actually, this is very interesting. Okay, what we try to call as an umbilical artery, right? So if I draw the anterior division, it continues as the umbilical artery, right? It has completely been obliterated because of adulthood. I mean, it is only active during when we were fetuses. Okay. And then it gives rise to this beautiful curvilinear artery. There is a concept of why God made only this artery curvilinear, you know. So people can ask this question, and I think we have not wondered about this enough. Why is it that the renal artery is not curvilinear? Why is it that the hepatic artery is not curvilinear? Why is it that the splenic artery is curvilinear only at a junction? Why is it that, you know, the celiac artery is not curvilinear? Why is it that the inferior mesenteric artery, superior mesenteric artery, all these arteries, why are they not like this? Why are they not curved? And why is it that all the other branches which the same guy gives out, the obturator artery goes out of the pelvis in a straight line. The pudendal artery, which goes underneath, it goes out of the pelvis in a straight line. Okay, all the other branches which come, middle rectal artery exits in a straight line. Iliolumbar artery goes down in an absolutely straight line. The anterior division is a straight line. The posterior division which exits the pelvis is a straight line. Why is everybody straight, and why is the uterine artery curved? Right? So if you ever do some research on this, okay, this is an embryological origin. The reason why I spoke about this, and that is the reason why we probably need to understand there is an anatomical correlation. Now, after the uterine artery comes, it breaks down into two parts. One, it goes down into the descending cervix, and then it forms the ascending uterine artery. This is what we know, correct? We never end up coagulating somewhere here. in the middle of the curved part. Whenever we want to do something to the uterine artery, either we are taking uterine at the origin where it is not tortuous, or in TLH, we are taking the anterior division and the posterior and the descending division. That means the ascending division and the descending division separately, isn't it? Never the curvilinear part, right? The reason why this is curvilinear is because embryologically, okay, there is something called as differential distortion which occurs in the uterine artery. We have explained this in concept of Mullerian anomalies. In Mullerian anomalies, we have explained a process called differential canalization. The entire Mullerian plates undergoes canalization at separate places, and then all these cavities join together. Okay, so probably God was aware that, you know, sometime in the future, okay, it is going to be the uterus which is going to go through menstruation. And when a uterus is about to going to go through menstruation, where the hormones like estrogen, progesterone, all these people are going to come and act on that particular uterus, this uterus will go through a lot of phases in a given cycle. It will go through a phase of expansion in the early follicular phase. It will go through a phase of shedding in the menstrual phase. So in order for that to happen, sometimes what will happen is this same uterus will become large in size. Globular uterus it will become in cases of adenomyosis. If it becomes even more globular, okay, it is going to be in pregnancy. In pregnancy, it is going to go very large. Sometimes what is going to happen is, no, endometriosis is also going to happen in the pelvis. So everybody is going to come and distort the uterus in some manner or the another. Okay. For that uterus and that fetus to get that much amount of vascularity, despite uterine distension, despite pelvic congestion, probably God made this artery as a curved artery, so that even if the uterus gets pushed on one side completely, this curved artery can then become a straight artery and it can still supply the blood to the uterus. Okay. Even if the uterus becomes completely retroverted due to severe endometriosis, there is a part of this artery which is initially curved and then starts getting straight in order to supply that uterus. Even if there is severe parametrial endometriosis, I'll come to that. Even if there is severe parametrial endometriosis go and kill that ureter, like how we had today. We had a ureteric endometriosis in the parametrium, right? Where we had to do Boari flap reconstruction, but nothing happens to the uterine artery, right? So that is the very interesting thing embryologically about the uterine artery. This is one of those rare structures in the human body which embryologically originates from two different people. Okay, one is it is originating from the Mullerian region, the blood vessels close to the aorta, and second, it is also getting a confluence which is coming from the umbilical arteries in the fetus. Because it is getting this double importance all the time, no, from all these different individuals, you have this type of a system which is coming inside the uterine vasculature, where it is the only differential artery which is formed embryologically. Okay, and this is something which we should keep in mind. So as gynacs, we are very lucky. Every day we go and we get to operate and cut and twist this artery which is actually coming from two embryological origins. So this is something which we should keep in mind. That is one thing, right? The second thing, as I drew and as madam had asked me to explain, anatomically, no, anatomical landmarks of uterine artery are the simplest landmarks God has created on earth. Okay, why are they the simplest landmarks? Because from the common iliac will continue into the external iliac, correct? And external iliac, the common iliac will also divide into internal iliac. The internal iliac will have an anterior division and a posterior division. The posterior division is like such a pavam. It will exit the pelvis within 1 centimeter of the origin. So it is gone. Remember, posterior division of internal iliac is something where we had recently operated one patient at Shilpa Madam's place, where we had to go and coagulate the posterior division. It is such a beautiful thing. It's the dilatation of the posterior division causes something called a superior gluteal vein syndrome, and we had diagnosed it and we had treated it, and it was so satisfying. After doing a beautiful surgery by me, patient came and went and kissed Shilpa madam. So such types of things can happen. This is due to the uterine artery. They don't know whom to go and kiss. Ideally, they should have kissed me. They went in the wrong direction from Bombay to Bangalore, and somebody else ended up getting the kiss, right? So these are the types of things which happen with the uterine artery. So if you look at the anterior division there, okay, after giving out the posterior division, there is the anterior division of the internal iliac. This is what we want to go and clip. This is what we want to go and ligate when we are in an obstetric emergency, right? So often we have to understand that through this, there is a small obturator artery, which I have drawn. See, it is a very small artery. You will see it only when you dissect the obturator region. Then there is a very big uterine artery, which I am drawing as a very curved artery. Okay. Then underneath that, it is going to give off a pudendal branch. That pudendal branch is actually very beautiful. We have demonstrated it many, many times on Facebook Live. And then there is an official ilionumbar branch. Now, sometimes you will also have a middle rectal branch, but middle rectal branch is a little inconsistent branch. But all these other people are consistent branches. Out of this, if you notice, I have drawn uterine artery the largest in diameter. Okay. The reason why I have drawn uterine artery the largest in diameter, and again, that is to do with something related to the hormones estrogen and progesterone as well as embryology. And this is why you have to understand this because of this vessel being the largest, okay, one of the largest bore vessels from the anterior division of the internal iliac. It is this vessel which is used for other markings. For example, we always mark parametrium. Okay, we always say that yes, this is the parametrium, right? When I draw the uterine artery here, and if somebody asks me, kindly show me the parametrium, I'm going to label the parametrium as the region surrounding the uterine artery. If somebody asks us what is the paravesical space, what is the boundary of the paravesical space? It is the parametrium. What is the boundary of the pararectal space? Oh, pararectal space. Very good, very good. Again, it is the parametrium. So everywhere you have uterine artery, which is being used as a landmark. One more thing you have to understand. Uterine artery is used as a landmark, and I've drawn it in different colors because these are embryologically separate components. Okay, this is what you need to understand in embryology, that you have something called as an embryology of the bladder, which is basically your urogenital component. You have the rectum, okay, which is basically the mesorectal component. And then you have the parametrial region, which is basically your mesometrial component. This mesometrial word is very, very important for people to understand because there is something in oncology called as TMMR, that is total mesometrial resection. Okay, it is not evidently practiced all across the world, but it is a very good concept which has been introduced over the last 10 to 15 years by a scientist in Germany, and it is purely based on embryology. All right. That is one of the reasons why you have in embryology that CA cervix, when it is involving the bladder and when it is involving the rectum, it is stage 4. CA endometrium, when it is involving the bladder and when it is involving the rectum, it is stage 4. Endometriosis involving the bladder and involving the rectum, it is stage 4 endometriosis. Okay. This is because it is called stage 4 predominantly because it has gone and met a completely different embryological compartment. All right. Now, some clinical points after understanding so much of anatomy. See, the best place if you want to cut this artery, you want to go and kill this uterine artery. Okay, so the best place is to go and cut it at the origin, right? Unlike what Shilpa madam just mentioned, that first I will cut and then I will coagulate. Actually, nothing like that is done by me. What I normally do to the uterine artery is, if somebody wants to go and coagulate the uterine artery, the first structure which you have to dissect is this guy, which is the ureter, which is going to go underneath. You know, there is some concept of bridge under the water, water under the bridge, whatever. Just understand one thing, that ureter is always going to go under the uterine artery. You can never have, even an ectopic ureter will go under the uterine artery only. Even an ectopic ureter, the only place where the ureter goes above the uterine artery is in cases of ureteric reimplantation, which is done by us. If God has gifted that ureter has to go underneath the uterine artery only because embryologically it originates from the urogenital sinus, and that part of the urogenital sinus comes up to meet the mesonephric region in the kidney. Okay, the only place it is available is underneath the uterine artery, because uterine artery is supplying the paramesonephros, and paramesonephros crosses the mesonephros in embryology. So there is no confusion in that. Don't by heart it. It is pure embryology. If you want to cut the uterine artery, as I mentioned a while ago, the best place to cut is here at its origin. Okay, that is why we always have lectures, no, uterine artery at origin. Have you ever heard a lecture uterine artery at middle? Okay, there is no such lecture which is available. The reason why it is not available is because the safest site to coagulate it as is at its origin. You have a long length available. At its long shaft length, you can coagulate. Often people ask, what is the best instrument if I have to cut the uterine artery? All instruments are equally good. See, you can use a scissor to cut, you can use a harmonic to cut, you can use a bipolar to coagulate and then a scissor to cut, or you can use a shearer to cut it directly. Usually, the bore size of the uterine artery, if we try to calculate, it is going to be less than 2.5 to 3 millimeters. Usually, okay, unless you have like a 36-week uterus, 34-week uterus, in that situation, maybe it will go to approximately 4 to 5 millimeters, nothing more than that. Even in pregnancy, uterine artery does not become 5 centimeters. Understanding that uterine artery is going to stay as 4 millimeter, 5 millimeter, even in a pregnant situation. So don't think that, oh, it is such a big artery. What is going to happen? Nothing is going to happen to the uterine artery. It is very, very pliable to be coagulated, clamped, ligated, torn. Even if it gets torn, you can just clip it, suture it, nothing. It's very forgiving. Okay. The other good part where you can go and coagulate is where it branches into inferior, I mean, that is into a descending and an ascending. At both these places, normally we apply our first clamp in abdominal or laparoscopic hysterectomy here. And after we have separated the Macken rods and the uterosacral, we apply our second clamp onto the descending artery so that there is no vault bleeding which occurs. Correct? No. And that is the other place where you can probably try to attempt. If you want to expose the ureter, very simple, cut the uterine artery here at its origin and then lift the uterine artery in the medial direction. Automatically ureter will get exposed, and that exposes something called as the tunnel. Okay, but I will be discussing about the tunnel in a different lecture altogether. I think this much understanding about anatomy, dimensions, pathology, physiology, and embryology of uterine is enough. I've spoken for around 15 minutes, and I will give the mic to Shilpa madam so that she can ask me clinical questions as far as this is concerned.
So you spoke about uterine artery at origin, but I still think 99% of the people are still coagulating the uterine artery very close to the uterus, ascending and descending branch, and then
Correct.
probably only few are doing it in retroperitoneum. So I mean, how do you do it? See, I mean, they have the textbooks say that in the open hysterectomy we have to apply the clamp perpendicular, and how to avoid the ureter. So when we are doing the right uterine from the ipsilateral port from the left side, so there is a chance of ureter getting injured on the right side. So what is your tips about to deal with it?
So that's a good question, ma'am. But remember one thing. The principle of coagulation of any blood vessel is very, very simple. First principle is skeletonization. That means you have to, what normally people do, they don't separate the posterior peritoneum, anterior peritoneum. Wherever they think there is a pulsation, they will just catch the entire, because you are used to doing that in abdominal hysterectomy. In abdominal hysterectomy, you are used to crushing that thing and then cutting it and then ligating it. Correct? No, there is no skeletonization involved in abdominal hysterectomy. So as gynecologists in our training only, we are not taught how to skeletonize. That's a very big problem. But the principle of ligating anything is skeletonizing it, right? So the first principle is skeletonizing. Second principle is traction, right? What happens? What is the meaning of traction? Why do you have to give traction? You have to give traction so that that curved part of the uterine becomes straight. Then you can go and apply your clamp, and simultaneously, if you have dissected the posterior peritoneum, then automatically ureter will fall apart. So when you mention from the left port to go and coagulate the right side, it is simple. Skeletonize it. Skeletonization principle is not going to change. But when you go and apply your coagulation, all right, the reason why you are asked to be perpendicular to that uterine artery is when you are perpendicular, your lateral thermal damage which is going to occur is going to be the most minimal. And when it is going to be the most minimal, even if you want, you will not go and injure the ureter. Correct? That is the reason why you are told to coagulate it perpendicularly. There is no other reason, frankly speaking. You can have a 10-degree tilt. Nobody is going to come and tell you anything.
So in these situations where you're talking about ligating it very close to the uterus, so do you have any landmark? Like, do you do it at the level of UV fold? Do you do it just slightly below the UV fold, above the UV fold? I mean, how do you actually?
This landmark is going to be keep on changing depending on the amount of adhesions which you have in the anterior compartment. Correct. So the best place to go and actually ligate is where you find the ascending branch. You will find the ascending branch almost always give a good traction to that uterus. Really, you will find that ascending uterine. Just go and coagulate that ascending uterine. Don't go by UV fold as a marker because let's assume a situation where UV fold is absent. For example, unicornuate uterus with a non-communicating horn. There is going to be no UV fold. So you can't really find the UV fold in that situation, right? So you should not go by that. You should go by the ascending branch. Where you see the ascending branch, that is where you go and knock it out.
So we are talking about, like yesterday we discussed that the bladder will never cross the uterine artery because of the embryo.
Never.
So uterine artery is actually a landmark when we do a lateral window dissection for adherent bladder.
Always.
So yeah, always. So many a times we find it that the uterines are static, like, I mean, there is not much of variation in the uterine, probably, like, the place where they are there. So in these situations, many a times the bladder is so badly stuck and you're not even able to get that thing. And we are not able to mobilize the bladder. In these situations, like, I mean, do you recommend that you just go even without the bladder dissection?
No, simple. In that situation, you go to uterine at origin. That is because you have the entire length of the uterine available for you to trace. Once you go to uterine at origin, bladder is not going to come and get adherent there. So from there, your dissection should start. If your dissection starts from there, you will free up the entire length of the uterine and bladder will go away. That will automatically create a window there. So no need to worry in that situation.
So when we are talking about, uterines, I mean, this is my observation. I don't know. I would request you to add to this. When the uterine is at origin, it looks a little smaller compared to when the uterine is closer to the uterus.
That is a matter of perception, madam. See, that is because you are comparing that uterine at origin to the next vessel besides it, and that is the anterior division of the internal iliac. If you end up comparing it to the obturator artery, you will feel, oh, what a big artery uterine is. No? So it is a matter of perception. There is nothing, there is no difference in the bore size of the uterine. In fact, it is one of those vessels where the bore size does not reduce till the organ. Okay. Otherwise, you have organs where the bore size keeps on getting smaller as they keep on giving branches. But that does not happen to the uterine, madam. And that is the principle which is exploited by interventional radiologists in doing uterine artery embolization.
Yeah. So you tell me this, when we are actually coagulating the uterines, many a times, like, with the shearer that you regularly use, or even with harmonic, there is some amount of bleeding which happens, and then we have to use the Bissinger bipolar. Where do you think we go wrong when we are doing it? I mean, in spite of replicating what we do in the open hysterectomy, we try and coagulate at 3 places and then cut it in between. Still, suddenly, like, like a jet, it will start coming.
That is because the coagulum which is formed is not a very strong coagulum. See, the difference is not between using shearer, harmonic, or bipolar. The difference is in the surface area which is acting upon that uterine. In a bipolar, you have a grasp, correct? So if you go by physics, no, the surface area which is forming the coagulum is approximately 7 to 8 millimeter in a bipolar. If you go by harmonic, it is maybe 2 to 3 millimeter. And if you go by shearer, then it is 1.5 millimeters. Correct. That is the reason when you use shearer and harmonic, because your coagulum is small, the pulse pressure of that uterine is going to push the coagulum and start sudden bleeding. With bipolar, what typically happens is because that coagulum is formed at a long length, 7 millimeter, very difficult for the pulse pressure to put 7 millimeter of coagulum away, which is why normal recommendation is if there is a vessel, skeletonize and then coagulate with bipolar and then cut with scissor or cut with harmonic.
So when we have done that and when we do the uterosacrals and then we try and close the wall, then suddenly you start seeing a sputter from the uterine. Okay, coagulum will be dislodged. In these situations, we try and, like, I mean, in a panic, start fumbling and start catching it anywhere, everywhere, and start pressing the energy source. So in these situations, what is your thing? Like when we are doing uterine itself, you think we should leave a good length of that uterine so that in case if there is anything, we can go down and
Anytime any bleeding or spotting at the level of the vault, it can either come from uterine artery
no, not at
or
the vault, not at the vault, from the
then
uterines only, from the uterine only. See, we have
acha,
coagulated it,
got it,
but
got it. That tampu, which we
yeah,
call, I don't know what it is called in English. Okay, that part, if it is bleeding, best is to go to uterine at origin and coagulate.
we can't go there. You tell without going there how to do it.
Okay, so if in case you are in a situation where you can't go there, one of the things which you should do is you should make sure, let's assume the right side of the vault is bleeding, then you go to that angle and pull that vault towards the left side. So automatically it creates some traction between the uterine, between the vault and that ureter on that side, right? Here, don't go and grasp that entire length and coagulate, because here your bladder and ureter will be very close despite you having dissected nicely. Because you are in panic, coagulate just the tip.
Yeah.
Once your tip is coagulated and you think that the field has become clear, kindly go to the uterine at origin and coagulate. The reason why I'm stating this is because you should not have a situation where you coagulated and you closed and then the patient started bleeding. And because in that situation, when you go inside, the only thing remaining with you is going to be to go and knock out the internal iliac. You will not be able to do any other step in that situation because of tissue edema. So keep that in mind.
So in cases like, large fibroids or abnormal uterine bleeding cases where the hemoglobin is very low, in these
Yeah,
situations, we see that anywhere you touch, they will start bleeding. Anywhere you want to coagulate, I mean, there is so much of bleeding happening. And in the forget about doing it at the origin. You tell us simply like how actually we should tackle the TLH that we are doing in severe anemia cases, especially like 7, 8, and we have given blood transfusion. But somewhere that coagulation profile is not very great, and the tissue, I think it is not very healthy. So how do you think we should tackle it?
see, if you are not confident about coagulating, then kindly use bipolar. Don't use sharer or harmonic.
So
Understanding?
yeah, in the bipolar, you think is it because the bipolar, as you said, the coagulum and the surface area is more? Is it why that it works better than the sharer or the
Absolutely. Absolutely, madam.
the
Energy source is the same
okay?
for sharer and bipolar. It is bipolar current, right?
Mhm.
It's just the difference of surface area.
Mhm.
With that, can you ever cut a tissue with bipolar?
No.
But you can cut the same tissue with the same current on sharer.
Yeah.
The difference is the mechanism in which the bipolar is acting on that tissue, right?
Correct.
And that is what you are exploiting in sharer,
Yeah.
isn't it? And you have to understand this, that if in case you are not very good, see, we always mention this, that sharer has a learning curve.
Yeah.
The reason why we mention is because you need to be somebody who is very good at skeletonizing things with the sharer, and then you can go and coagulate. If you are not good at skeletonizing a structure and if you use a sharer, you will have fistulas. Understanding? Which is why, if in case you are not confident, then the better option is very simple. Just use your bipolar.
So, what are the situations where you think harmonic is a good instrument or not such a good instrument when it comes to the vascular, like when it comes to only dealing with uterine?
Uh, Nobody beats a bipolar as far as vascular anatomy is concerned.
Hmm.
In fact, if you look how we studied vascular anatomy, in vascular anatomy, we don't even use bipolar. We actually use clips and then we cut in between the clips. Nobody even trusts bipolar because nobody can knock out a clip. That is not going to happen. So the safest is the clip. Surely, surely the safest is the clip. No question in that. You want to use something else, bipolar is better. You're supremely good as far as knowing your anatomy and pinpoint accuracy is concerned, then probably sharer or harmonic.
Yeah.
Okay. But I mean, if we in case we are educating people, then education should be to go with the clip. And if not the clip, then with the coagulation with bipolar.
So, in your practice, I know you do a lot of advanced surgeries, and retroperitoneum is like you do it like 10 times in a day and all that. But for beginners who want to actually have a safe practice laparoscopically and deal with like, the situations where they are practicing alone as a single independent consultants, and they need to learn this uterine artery at origin or to know it. What would be your best advice to all of them?
The best advice to learn uterine artery at origin is to open uterine artery in simple cases.
Okay, and how do you prevent this the back flow when you cut the uterine artery very close to the uterus? No, I mean, do you say that the back flow, whatever happens from the medial end? I mean, can you do something about it, or
Just coagulate above it. It will stop.
Yeah. Yeah, I think we are good. Anything else you have forgotten? I don't think so. We'll deal with it on queries from the WhatsApp. But thank you. It was wonderful to know about the embryology. I definitely did not know about it, though we had spoken a little bit about it in our Mullerian class in the fertility masterclass. So I hope all of the people who have logged in, I think this is a very, very, very important and a very unique class which everybody has to watch at least once or twice. It makes a lot of concepts very clear when we are actually doing a TLH or when we are actually struggling with vascular, I think, troubles. So please watch it once, twice.